PAHO WHO representative Dr. Gitares Gebre, distinguished members of the panel, invited guests, ladies and gentlemen, a pleasant good morning to all. The latest WHO estimates indicate that over 16.7 million people have been infected with COVID-19 virus, and of this total, 9 million were reported from the region of the Americas, including 105,000 from the Caribbean region. Such statistics were made possible by available capacity for COVID-19 testing at global, regional, and national levels, and continue to guide policy decision makers in our region in the efforts to stop further spread of the disease. When the pandemic reached the Eastern Caribbean in March 2020, only Barbados, Dominica, and the French departments had the equipment required for making a diagnosis of COVID-19 in the national reference laboratories. 3 months later, all OECS member states and UK territories have now acquired such capacity and trained their staff on the use of molecular technology for the detection of SARS-CoV-2, which is the cause of COVID-19. During this period, a total of 21,226 tests were done in Barbados and the Eastern Caribbean, with an overall yield of 8,392 laboratory confirmed cases as of 27 July 2020. In this webinar, we will hear how countries and territories managed to build their local capacities in such a record time, the issues and challenges they encountered during this process, and the testing goals and strategies as they reopen the borders to regional and international traffic, taking into account available resources and limited testing options. Without any further ado, I would like to invite Dr. Gebre, our representative, to take the floor and bring his remarks before we proceed with today's agenda. Over to you, Dr. Gebre.
Okay, thank you, Dr. Jean-Marie. Good morning to all of you. Scaling laboratory testing for COVID-19 is the session this morning. The global crisis is far from over. The health crisis has evolved into severe socio-economic crisis and issue. As Dr. Jean-Marie mentioned, 16.7 million people are infected. 650,000 have lost their life today. 10% of the cases are increasing weekly in the global cases. $375 billion are lost per month due to the COVID-19. And over 6 billion people are now affected throughout the world through this pandemic. Next slide. This morning, we'll be looking at to provide guidance on the recommended methods for COVID-19 diagnosis. We will share country experiences and lessons learned on COVID-19 testing. We also discuss opportunities and challenges for maintaining adequate COVID-19 testing capacity in the Eastern Caribbean countries. As you know, there is an immunity gap at this point in time. There's a substantial gap in immunity to COVID-19 globally will result in continued and substantial waves of diseases throughout at least the end of 2021. This also may result in straining the health system and further disrupting the societies and economies. There are multiple potential approaches to change the spread of this virus and the profile of COVID-19. By doing this, especially restoring the functions of society and economies. Currently, what we have is innovation to have a new solutions of the use of testing. Next one. Why do we need testing? Why do we need diagnostics? As you recall, the Director General of World Health Organization have said many times to the countries, test, test, and test. So why do we need testing? Testing is essential at every stage of the pandemic response. Effective diagnostics are essential to limit the spread of infections. Many countries have shown that test, trace, and isolate works. But the other T also is important, treatment. The first diagnosis has been made by testing. Currently, we have done also to the test and treat information where individuals are able to be accessing, because of their severity of illness, new treatments. Testing also is important. If we have vaccination, we have to test and vaccinate. Overall, to confirm the pandemic is defeated, we need testing in our systems. Next one. So how can testing help save lives now? In early targeted testing helps to isolate cases, manage patients, and prevent the spread. Early, repeated testing is very essential. For every death we are averting, we have to do as many as 1,000 tests. Next one. And this also testing will help us to prevent repeated lockdowns. The stronger the country testing capacity and development and having a better testing strategy, the better the outcome for the COVID-19 response. Testing is vital to both mitigating direct impact from COVID-19, as we have seen right now, also minimizing the knockdown on other impacts on HIV, TB, and other diseases, which we are now also fearing an increase due to COVID-19. Next one. So we need to seize this moment, the window of opportunity, and put in place the right conditions for large-scale testing and the right strategies now. Currently, middle-income countries, low-middle-income countries are trailing by doing only 10% of the test, which is done globally. The 90% of the tests are done in richer countries. So what are the barriers for why we cannot have testing? Then what is needed to be done? We're going to hear this one from Dr. Lionel Gresh, our virologist, on the current testing strategies and then what it means. The current testing strategies rely on systems and infrastructure which are complex, expensive, slow, laboratory-based, resource-intensive. Do we have new ones? There is also a supply shortage, which also jeopardizes access. Manufacturing capacity is not in place to rapidly scale up production of tests to meet the global demand. Rapid diagnostic tests need innovation. There are so many issues related to rapid diagnostics. Need to be faster, more accurate, more affordable, easier to use in any locations. Next one. So we have to invest on testing. Every dollar we invested in testing today is a dollar invested in our future in the Eastern Caribbean. Health, security, and opportunities to protect the health and advances of recent decades. Thank you very much. Back to you.
Yeah, thank you very much, Dr. Gabriel, for your opening remarks, which expanded a little bit on some of the issues that we are going to be discussing today. So we are going to be proceeding with the technical presentation by Dr. Lionel Gresh, our colleague from PAHO, Washington. And as you can see on the agenda, we have a series of country experience sharing. We have 4 of them. And then after this country sharing, there will be some questions and answers. So we invite the participants to use the mic. You can raise your hand, and or if you prefer to type your questions, please do so that we can really have a very interacting session. So we are going to be proceeding with Dr. Lionel Gresh. Dr. Lionel Gresh is a graduate from Pierre and Marie Curie University. He holds a PhD degree in human genetics and molecular biology. Since February 2017, he has been working for PAHO WHO Regional Office as a laboratory specialist. In his current position, he provides technical assistance and advice on laboratory diagnostic techniques. He conducts assessments of national public health laboratories, provide guidance on appropriate collection, conservation, and shipping of specimens for laboratory diagnosis. He organizes training workshops, seminars, and technical cooperation with member states to address gaps in laboratory-based surveillance and diagnosis. And finally, he contributes to surveillance and laboratory guidelines and recommendations. So, Dr. Lionel Gresh, you have the floor for your first presentation. Over to you.
Thank you very much, Dr. Jean-Marie, for the introduction, and thank you, Dr. Brie, for the introduction. Okay, and I'd like to thank Dr. Gibri because he mentioned some of the things that I was going to mention, so I've hopefully a shorter in my presentation. This presentation will focus really on the guidance for laboratory testing, and just to put it in context, these were the numbers on the 11th of February when we're just finishing the first training for COVID-19 testing in Barbados. So a very quite limited spread of the disease. Most of the cases that were detected outside China were at that time travel-related cases, and there was no community transmission. And contrast with the current situation with a widespread circulation, as I was mentioned, as it was mentioned already, and to also highlight that currently half of the cases and half of the deaths, more than half of the daily cases and deaths are come from our Bajo region. So back to the virus that is responsible for this disease. So early in January, this new virus was identified as a novel coronavirus. So coronaviruses are part of a large family of viruses that is divided in subgenera, in genera, alpha, beta, and so on and so forth. There were already some coronaviruses that were known to infect humans. Some of them circulate endemically in human populations, and some have emerged from zoonotic spillovers in the past 20 years. So within the beta coronaviruses genus, there are a number of coronaviruses that are known to infect humans. Here in this phylogenetic tree, you can see 5 of these viruses, 2 down here that are viruses that infect, that circulate endemically in many human populations, and 3 others, MERS coronavirus and the SARS coronaviruses, to start with, that have emerged recently in human populations. And then the last one, which was still called here 2019 novel coronavirus, which is the SARS-CoV-2, the virus that is responsible for COVID-19. And all these 5 viruses belong to the same genus of the coronavirus family. And a point that is important for diagnosis, SARS coronavirus and COVID-19 virus both belong to the same subgenus that is called sarbecovirus, and I'll come back to that in a moment. Also, it was mentioned by Dr. Gibri, very important in trying to slow the spread of this disease is to detect and isolate cases timely and trace and quarantine contacts. There are a number of PAHO and WHO guidelines for each of these functions, and I'm going to focus today on the latest laboratory guidelines for the detection and diagnosis of COVID-19 virus infections that was published a couple of weeks ago, and also take a couple of elements from other WHO guidelines that are related to this detect function. So as any other infectious disease, there are broadly 2 ways we can detect an infection. One is what we call direct virological techniques, where we detect directly a component of the virus. That component could be the genome of the virus, or it could be a protein or a glycoprotein, what we call a viral antigen. The other way of detecting an infection is indirect, so it's through a serological method where we don't detect directly the pathogen, but we detect the effect, so the response to infection through the detection of antibodies that are produced upon infection. So, of course, the use of these techniques are determined by the natural history of the virus, but the viral dynamics. And what we know currently is that present in the respiratory tract samples, both upper and lower respiratory tract, probably from 2-3 days before the onset of symptoms to 7, 14, or even more days after symptom onset. We know that the virus can be detected in the upper respiratory tract, and the sample of choice that is recommended right now is the combined nasopharyngeal and oropharyngeal swab, although single nasopharyngeal swabs can also be used. The virus can also be detected in the lower respiratory tract, but that's a sample that is more difficult to collect. So that is only collected in certain cases of severe patients. And these samples need to be transported in what we call the viral transport medium, for which there are commercial and in-house produced versions. And there are studies that have shown that this can also be replaced by sterile saline or nucleic acid preserving solutions in case of shortages. Samples should be shipped to the laboratory in what we call a basic triple packaging to ensure biosafety, refrigerated and processed as quickly as possible. I'm just gonna quickly mention the potential use of saliva. That was a new addition to our guidelines, and our recommendation right now is that more data should be gathered on that, and that there is conflicting data out there, and probably the sensitivity of the detection of the virus in the saliva compared to the upper respiratory tract samples is lower. So if we dive now into the techniques that for the detection of the virus, of the viral component, what we call the virological methods, we have first and foremost the recommended method, which is the RNA detection through a nucleic acid amplification technique that is called RT-PCR. Just want to point out that there are now dozens, if not more, of commercial tests that are available for the detection of COVID-19 RNA. And there is an extensive independent evaluation work that has been performed by FINE, which is a WHO collaborating center that is specialized on diagnosis, that has conducted independent evaluation of this test. So I would recommend that whenever a country is considering purchasing one of these commercial tests, that their performance in this list of verified assays is checked and analyzed carefully. I just want to point out that these evaluations were performed against the protocol, the in-house Charité Berlin protocol, which is the protocol that we've been recommending in the region, and which I'm gonna describe quickly now. A protocol that was the first protocol available on the WHO website for the detection of COVID-19 virus is composed of 3 different assays that detect 3 different portions of the virus very quickly. From the beginning, we focus on 2 of those. So the detection of the E gene of the virus, the envelope, which is similar in many of the SARS-CoV-viruses. So that's a test that will detect any virus and not only COVID-19 virus. And then a test for the detection of the RDRP, which is the viral polymerase that is 100% specific of the COVID-19 virus. These tests have been, these assays have been extensively studied. In particular, their specificity against other circulating coronaviruses or other circulating coronaviruses have been analyzed. Whether it's the alpha and beta coronavirus that circulate endemically in human populations, or newer coronaviruses like MERS. Context, we have developed and updated our laboratory algorithm. As you might be aware, the initial recommendation from FAO WHO was to detect 2 different genetic targets of the virus to have a confirmation of the case. But of course, in the current epidemiological context, we realize that a simpler algorithm increases laboratory capacity, increases turnaround time. And if we use an assay that is really fit for purpose, unlike the Charité assays we've been recommended and stringent quality control, we can ensure accuracy while we use a single genetic target. So that's one of the updates of our algorithm. And when choosing one, we have realized, in particular with the feedback from many of the laboratories in the region, that the E-gene assay has a slightly higher sensitivity. And because it detects subrecoviruses, one might think that it is not a fit for purpose, but actually the only subrecovirus that currently circulates in human is the COVID-19 virus. So it's perfectly safe to use the E-gene as a target for confirmation. So and this is the new algorithm that has been published in the updated guidelines. So included in this guideline, the antigen detection based and an antigen detection based laboratory algorithm, as you can see here. So during the first days of infection, at the same time where the virus is replicates in samples, you can detect viral proteins, and this can be detected through a different number of types of tests, ELISA, immunofluorescence, or even a rapid diagnostic test. What is really important to mention is that the antigen detection assay should undergo independent evaluation, so independent from what the manufacturer claims, to establish diagnostic performance. This has not been done by FIND yet, but it's in progress, so we might have some data to share on that soon. And in general, what we expect is that this test would have a good specificity, so that they could be used as a confirmation criteria. However, a negative result should not be used to rule out a case, because we expect that these tests have a lower sensitivity. And because of that lower sensitivity, one should consider when these tests should be used. And the algorithm goes as a positive antigen test will confirm a case, while a negative will need to be confirmed using an RT-PCR assay. I want to mention that in terms of testing and discontinuation of transmission-based precautions, or what isolation, there's been a couple of new documents from WHO that have described strategies to decrease the number of testing. In particular, are for symptomatic patients. It doesn't require testing of symptomatic patients to release them from isolation. So it's just based on a number of days since after symptom onset, plus a certain number of additional days or where the patient should be asymptomatic. So the patient should be isolated for a minimum of 13 days, but that can be, if the patient has clear symptoms for more than 3 days, it can be cleared from isolation without additional testing. And the same for asymptomatic case. The recommendation now is that 10 days after the first positive test, there's no requirement to perform in the general population, in the general context, to perform additional testing to ensure that the patient can be released from isolation. In terms of serological testing, very quickly, what we know of the immune response to COVID-19 is a bit different. We know now it's a bit different from other viruses. We know that the sensitivity of the detection is very low during the first 2 weeks of infection, so that in most people, antibodies take time to be produced. Of course, antibody detection only indicates previous contact with the virus, and we don't know yet if those detected antibodies are protective, and if they are, for how long they might be protective. We also don't know if these antibodies, for how long these antibodies persist. Just some data, just to give you a sense of what's the expected sensitivity of this antibody test. This is pulling any type of antibody test, including rapid diagnostic test. Sensitivity that's very low in the first 7 days, around 30–40%, that goes up to 60–70% on the second week, and only reaches a reasonable level after 2 weeks after symptom onset. So because of that, the current recommendation is that serological tests are not considered as a diagnostic test, that if they're used, the results should be always carefully evaluated in the light of clinical information and epidemiological context. In particular, we don't recommend the use of rapid serological tests because of these limitations I've mentioned, plus additional limitations that might be linked to the manufacturing of these kits. And the implementation should be focused on the epidemiological research and seroprevalence studies. Before I finish, I want to touch on the procurement of reagents for COVID-19 tests from a PAHO's perspective. So through the PAHO Incidents Management System and Emergency Operations Center, we've been providing countries with primers and probes for the recommended charity protocol. This will continue. We also have a limited supply of swabs extraction kits and RT-PCR enzymes. PAHO has been participating in the UN-wide and other organizations, Global Health Organization, COVID-19 supply chain system. It's a diagnostic consortium that was established to promote access to diagnostic kits in low and middle income countries. And there is a catalog of kits that are available on this under this diagnostic consortium that can be that is available in the internet. This combines open platforms RT-PCR kits that are similar to the ones I was mentioning from the Charité protocol, but also closed platform kits, like, for example, the Expert cartridges, although the supply of these is very limited at the global level for low and middle income countries. And then there's also some of these kits, the open platform kits, that can be procured through the PAHO strategic. So to wrap up, I'd like to say that there's still a lot of unknowns, in particular regarding the dynamics of the infection, the dynamics of the infectivity, and the immune response against the COVID-19 virus. That will, of course, update the guidance as new evidence is generated. And in this context, the feedback we get from the public health laboratories or other laboratories conducting tests is very important. And of course, and that's the objective of today, that scaling up and decentralizing testing is important. Yet we want to do this with on the right person, with the right test, and ensure that the results are really timely available for action, both at the individual level and at the community level. I want to emphasize, as this is a collective effort of our laboratory response team at the PAHO Health Emergencies Department. You might know some of the members of the team. And I'll also like to take this opportunity to thank the laboratory leadership and laboratory teams in the region. It's really been a great pleasure to work with you all, and it's really amazing from the first mission in Barbados, I think it was back in 2015, how the lab capacity has grown and how we've been able to all together still grow this capacity even without being able to travel and function in the normal way as we were used to do. So thank you very much for your attention, and I'll take any questions. Thanks.
Yeah, Dr. Leona, thank you very much for your very clear presentation. Of course, there will be some questions to be asked by the participants. I noted in your presentation, you mentioned that there is no need for doing e-gene or an RDRP gene in a series. This is very, very important because we know that the supplies on the market are not really always available. So we need to make sure that we are cost efficient in the way we use these antigens. You also mentioned that antigen detection has some role in confirming COVID-19. This is good news, but for the rapid tests, antibody tests, we still have a long way to go because they are not being recommended for diagnostic purposes. It's only for seroprevalence surveys and epidemiological research. So I want to open the floor for any questions to Dr. Lionel Gresh. You can either raise your hand or you can type in your question, whichever you like.
I think I saw one question on isolation, but I have the PowerPoint up. If you can read that question, please.
Okay, I'm trying to see where is it? Okay, Brenda, can you see the question read out for me?
Dr. Gresh, where did you see the question? I'm not seeing it.
I don't know. It popped out for a second on my screen.
All right. So, well, maybe we can come back to.
Explain. Sorry, from Paulette Cheltenham. Oh, this was sorry. It was sent privately, so that's maybe why you cannot see it. So please, when you ask your question, ask it to all participants so we can all see it. So the question was the rationale for not testing those who are in isolation who are due to be released. Yes, and I went a bit fast on this in the interest of time. So basically what we've realized, and there's a growing evidence on this, is that people might still shed viral RNA, so might still be positive by RT-PCR for long periods of time. I think the longest right now it's more over 2 months of RT-PCR positivity in a person that was that had recovered from the symptoms of the infection. But what we could see is that despite the fact that these people had prolonged viral RNA shedding, all the evidence pointed towards that these people not being infectious anymore. In particular, if you try to isolate virus from these patients, from their samples, virus is very rarely isolated more than 10 days after symptom onset. So that was the rationale of recommendation. In particular, there was a lot of data shared by South Korea that has done a good work at tracing all the infections and all the cases and the contacts. And that's why the recommendation was changed. So all the evidence points, and there might be a few exceptions in people who are immunocompromised, for example, but all the evidence points towards the fact that people are not infectious for more than 10 days. So they might still be RT-PCR positive, but they're probably not infectious. So that's why the general recommendation is 10 days, a minimum of 10 days after symptom onset, plus 3 additional days without symptoms. So that would be in total a minimum of 13 days. And if you had symptoms for 2 weeks, then you'll have to wait for those 2 weeks of symptoms plus 3 days where you've cleared the symptoms before you can be released from isolation. And the same rationale applies to asymptomatic cases. So if you identify an asymptomatic case by RT-PCR, then you are almost quite certain, let's say, that 10 days after that person is not infectious anymore. Over.
All right, so I can see, Gabriel, you have your hand up. Let me give you the floor. Gabriel, go ahead, please. Ask your question.
Hello.
Gabriel,
Good
yes.
morning. Good morning.
Yeah, we can hear you. Proceed.
Thank you very much. Good morning, Jean-Marie. Good morning, everyone. Thank you, Dr. Gresh, for that very interesting presentation. Yes, I raised my hand to ask you 2 things. Number one, and I put that on the chat. But my first question is, a brief comment from you, please, with regards of the use of other regions, target regions like N, ORF, et cetera, and if they can be considered for the use in the public health setting. That's number one. And number two, and this has been a long discussion with some colleagues across the region. If it has been considered a threshold for the e-gene, because the system appears to be very sensitive, and we see very often values more than, sigmoidal curves with values more than 37, and this corresponds normally to very old cases. Cases that are not in the infective part of the disease, and this can produce some sort of confusion, and it has, of course, implications for the use of resources and for the way on how we report these positive or presumptive positive cases to the public health system. Thank you very much.
Thank you, Gabriel, for your question. So about the other regions, I think there is no general rule on what's, so when I talk about E-gene or RDRP gene, this is really, it's a shortcut for the E-gene piece that is detected by this specific Charité protocol, right? So there is no general rule for the inclusion of other regions. I think the only thing I would recommend, especially for countries, and this might be different for you at CARPHA, where you have a wealth of samples, but especially for countries that have limited capacity to do their own independent evaluation per se, to rely, at least as a first screening, in the independent evaluations that were performed by FIND. As you can see in some of the kits that work well, for example, the one-type kit that detects ORF1A, B, and N, the sensitivity and the specificity compared to the recommended Charité assay is 100%. So there's no one N and one, only one N test or only one E test. So for example, the CDC test that also detects different parts of the N gene, some of the components of the test have problems of specificity and others don't. So I would rely on these FIND independent evaluation by FIND first, and then of course on your internal verification process. Regarding the threshold on the e-gene, Charité e-gene protocol specifically, you're totally right. It's a very sensitive assay, so it picks up people that might be shedding very low amount of RNA, and as I just mentioned, these people are more likely not to be infectious. So there is no established threshold. In the commercial version of this e-gene kit, the initial versions set up a threshold at 39. So, and it's very interesting that you mentioned that, because one of the rationales actually that I didn't mention for the release from isolation was also that lab capacity, the thing you just mentioned, and the fact that these low positives that then could be negative one day and then positive the next day and then negative a couple of days later will also create some kind of mistrust in laboratories, and that this was very unnecessary, as if we follow these rules for ending isolation. Over to you.
Okay, so thank you very much, Lionel. We are going to be reading some questions from the Q&A. Brenda, can you just read a few questions for Lionel?
Sure. Is the recommendation now to consider moving from a closed platform expert to an open platform bundles, given the limited supplies or difficulty in getting supplies? There's also another question. Is there any difference between the different PCR machines, those available in China, Venezuela, USA, etc.? And do you want me to read all of them, Dr. Gresh, or?
Maybe I'll take, I'll take these two. So again, regarding the open versus closed platforms, I think, again, there's no rule that you cannot use a closed platform or anything of that sort. I think you have to take into account two things. One is the performance of the test. And FIND has conducted some of these independent evaluation, at least for two of the what we call near point of care closed platform tests, the Gene Expert and the MolBio that are shared on their website. So I think it's really, again, so one factor, of course, is the performance, and the other factor is the availability, right? So I think it'd be very nice for many countries to decentralize testing using the Gene Expert platforms, because those are widely available, easy to use, do not fully require biosafety level 2 laboratory. So all of these factors, but unfortunately, in this case, we don't have the right supply of these cartridges. So as a recommendation, I would say, yes, if you can expand your open platform testing capacity, it's good, because that works now, that will work for influenza, that will work for other pathogens, and that will work when we, hopefully, we don't have to live through that, but for the next pandemic. Over. Oh, and so the second question was about the PCR instruments. I think that's they're very, what you have to check is the fit between the tests you want to use and the PCR instrument you're procuring. So, for example, the Charité assay is a very simple assay in a way, so you don't need a very high-tech PCR machine, like I would say middle range PCR machine. Other commercial kits might be multiplexes or a bit more complex, and that might require a higher end equipment, but you just have to match the test you're planning to use with your PCR instrument. Over.
Okay, can you say a bit more about the antigen tests and their use for confirmation? I know you said that FIND, F-I-N-D, is doing work on these. Is there a timeline on expected outcomes of FIND's work? Which tests are being looked at?
Okay. For which tests have been looked out, there's a list. I won't go through them, but there's a list on the FIND websites of the tests that are being evaluated. On the timelines, unfortunately, they had set up, these are studies you need to do prospectively because of the need to process the sample that was freshly collected, which is a bit different from the evaluation of the open platform RT-PCR assays, where they did use sometimes retrospectively collected samples. So they've set up initially sites in Europe, and by the time those sites were ready to start, the epidemic was going down there. So now they've established sites in South Africa and Brazil, where they've seen, unfortunately for the countries, a very high positivity rate. So I think we can expect that in the next month or so, we'll start having at least the preliminary results for the antigen detection-based assays. If I'm not mistaken, at the moment, they are evaluating 6 or 7 of those. So until we really have those independent evaluations, it's a bit difficult to know how we're going to use them. The expectation is what the algorithm is based on. The expectation is that these tests are less sensitive than PCR, but probably as specific as PCR. And because of that, you can, if the test is positive, you can say that's the case. If it's negative, then you don't know. That's the general idea. Over.
Okay, and final question in the chat. If an individual is symptomatic for only 5 days, do you just wait the additional 5 days to discharge? I ask because the slide says a minimum of 13 days.
Yes, so that's that was a bit in the wording in the first guideline, was the clinical management of COVID-19 guideline was a bit guidance was a bit unclear. So then that was clarified in the second document. These two documents are available online, and I can also share them with you. And it's it's a minimum. Basically, the minimum is 13 days. So even if you have symptoms for less than 10 days, you should add 10 plus 3. And I agree with you that the wording is not very clear, but it was clarified. The explanation of it was clarified in the second WHO document. Over.
Over to you, Dr. Rangoba.
Okay, thank you very much, Brenda. All right, so I'm very happy that we got so many questions, very, very practical questions. These are the questions that clinicians have been asking, especially with the discharge. When do we really discharge the patients based on RT-PCR results? So we are going now to be proceeding with the second session, which is going to be our country experiences lesson learned. So I will start with Barbados. The presentation will be made by Ms. Sonji Beckles. Ms. Beckles has worked in laboratories for approximately 25 years and has been involved in molecular diagnostics for more than 20 years. She comes with vast experience in manual and automated PCR testing systems, including testing for leptospirosis, sexually transmitted infections, HIV drug resistance, arboviruses, and respiratory viruses. Since 2018, she holds the position of laboratory director at the Base dos Santos Public Health Laboratory in Barbados, where she is responsible for the management of COVID-19 testing. Prior to this position, she worked as a clinical information specialist at the Vladimir Reference Unit Laboratory from 2002 to 2017. So, Ms. Beckles, you have the floor. Please proceed with your presentation.
Sure. Thank you very much, Jean-Marie. Good morning, everyone. And thanks for PAHO for the invitation to actually outline what our experience has been like in Barbados addressing the issues. Can I have the next slide, please? So what I'll just walk you through is some of the things that we actually encountered and some of the things that we actually did to try to mitigate some of the factors or the challenges that we did have. And so when we first started, when COVID-19 first came on the horizon, and actually PAHO reached out to us and offered to do training for COVID-19, we were very receptive to that fact. But of course, there were certain things that we had to then ensure we had in place or to start thinking about at least. And we wanted to ensure in terms of our risk assessment, did we have the appropriate mechanisms in place in the lab to be able to handle samples coming in for COVID? So we looked at our what safety requirements would be needed, what procedures there were out there in terms of sample handling and processing, and of course, what were the appropriate PPE to use actually if you're going to be doing testing. What were also very important to us was to have SOPs for the handling of transport and handling of samples, and of course the testing SOPs. Even for influenza testing, we've had challenges in the past with persons submitting samples to the lab for flu, for influenza, and so we figured that some of those same factors or issues will come out again because it's the same sample type. Then in terms of our capacity, we look at what kind of equipment do we have? Do we have the equipment that we can actually use to perform this test when we looked at the charity protocol? And of course, based on that protocol, and we also had the Quant Studio, which we use normally for influenza testing or other arboviruses as well. And we said, okay, we have the equipment that we can start this if needed. And of course, the other PPE that were important to make sure we have in good supply, of course, the handling of the samples on the biosafety cabinet. So we want to ensure they were all certified. Have enough supply of lab coats and gloves, masks, etc., any other PPE that we thought was necessary. Next slide, please. So our training actually took place in the very early days in February, the 10th to 11th. And there were 6 of us that were trained by Dr. Gresh. And all 6 of the persons involved had a fair experience in molecular diagnostics. Majority of them were already doing testing for influenza using the ABI 7500. So the technology or even sample extraction, amplification, all of that, they were already doing. So it's easy to transition just a new test, a different protocol, and to go on like that. Of course, within our training process, we had a verification. So we had known controls that we were using to verify that the procedure worked on our instruments. And our training was like a 2-day training, 10th to 11th. And really, by day 11, we already had persons submitting samples. I remember we were very excited and scared at that point, because we actually got a sample from one of the clinicians saying possibility of COVID, and they wanted us to test the sample even before training was complete. So that was kind of exciting and scary at the same time. And to get us going, PAHO did provide the initial reagents for us so that we could at least start right away, and not that we'd had the training and then have that lag of now having to procure reagents to do the testing. So that was a boost for us as well. Next slide, please. So we, like I said, started in February. After the training, by the next week, from then on, we were testing at least once or twice a week, the samples coming in. And to date, we have done over 11,000 tests. What has helped us to be able to reach this large number is that we have had continued support from PAHO. So I must say, procurement is an issue, I think, all over. And at times when we were in dire need of running low of stuff, we could always, we are running low on this. Can you assist us in any way possible? We also did have some support from some of the other islands. I remember at one point we were running low on swabs, and one of the islands gave us some swabs. They had a fair set that they were able to give us a few, and they needed extraction reagent, and we did a quote unquote exchange. I gave some extraction reagents and they gave us some swabs. So that worked well as well. But what I think has really helped us to continue and to maintain where we are, we have a very high level government commitment and financial support to this entire effort. Straight up from the top, from the Prime Minister, she's on this, I think every day. She's having discussions and meetings in one way or another, dealing with how we handle COVID-19 in country. And so this type of support has trickled down and helped us to be able to get all the resources that we need to continue doing testing. And of course, with her support, then it trickles down. The Ministry of Health is always there. Technical persons there help us as much as they can in terms of ensuring that our procurement is done in a timely fashion and that things are expedited. We have had the IAEA actually coming on board as well, and they have donated equipment and reagents to actually do testing as well. We have had quite a few donors who have been assisting us in different ways. Some have actually offered to buy equipment or
Ms. Beckles, we can't hear you. Did you mute yourself by mistake?
She's probably disconnected.
Okay, should we move on?
Can you hear me now? Hello?
Yes, we can. Go ahead, please.
Okay, so I'm not certain where I dropped out because I was not. Okay, so what I would say, I can just start from this slide. What I would say is that help us to get to the 11,000. It is support from PAHO. PAHO has always been there to assist us when needed. At times when we are low of reagent or supplies, they have assisted and have come forward and stepped up and offered us some assistance in terms of procurement of extraction kits or even primary, etc. Our government commitment has been really, really strong, with our Prime Minister offering to ensure that the lab has all of the financial resources available to continue to meet the demands of COVID testing. And our Ministry of Health continue to work with the government of Barbados to help us to expedite all of our orders to ensure we have our resources in a timely fashion. We've also had the support of IAEA, who have donated reagents and equipment, which has allowed us to set up additional stations within our lab space to be able to extract and process samples. We've had the philanthropy support of many donors in country offering to purchase reagents or supplies, or even just helping us source some of the reagent supplies that we were having difficulty acquiring on the market. We've had the support from other government entities, other government labs, again, because there are only 6 of us from the lab that were involved in the COVID testing. Then when our numbers started to get fairly high in terms of our daily numbers, we had a discussion with the Ministry of Agriculture, who had staff that were trained in molecular diagnostics. And they actually came over and we trained them, and they assisted us with some of the activities that we needed to do. And they even offered reagents and supplies. So they also had similar equipment or some of the supplies that we would use, and they would, even if it was just simple things like pipettes and tips, they would even bring some of their stuff to ensure that we have everything that we need. So they have really supported us along this way as well. What we have had in terms of, we have continued to procure our reagents. We had an automated extractor within the lab, but we were not using it because our volumes for influenza were quite small. So we were not using it at the time, but once we realized that our numbers were climbing in terms of requests for COVID testing, we actually then procured the reagents to actually use the automated extractor machine, and then of course increase our capacity, our orders for test kits and swabs. It continues to grow for us. And now that we have opened our borders officially, I don't think they were ever really closed, but now that we are having commercial flights coming in to country, again, we tell persons that they need to walk with their test, and if it's not validated or if they don't have a test, we actually have a station set up at the airport where persons are swabbed at the airport. The samples are sent to the lab, and in most cases, persons have to remain at the airport until return results, which can take anywhere between 6 to 8 hours once the samples actually land at the lab. And the reason why it can't take as long is because obviously there are a lot of other little things that we need to do in terms of accessioning and ensuring that we have our unique identifiers for samples. But along with that as well, it means that how we set up our assay, we can only do approximately 25 samples on each machine at any one time, based on how we give enough space to make sure no cross-contamination, etc. And that meant for us, if we're having large numbers of samples, sometimes over 100 samples coming from the airport, it can take a while. And so then what we immediately did, and what actually had done from early in the whole COVID procurement, was I had heard that the Roche system that we use for chlamydia and gonorrhea and HIV has an open channel that we can actually use, and that machine can do 94 samples at a time if you have that volume one time. And so from very early on, I had ordered some of the reagents, but the same PCR primers that we were using can be used on that machine, but also I had ordered the master mix that is specific to that machine, just in case. That took a while to come to the lab, actually. It took quite a few months for us to actually arrive, but we had already started thinking in terms of increased capacity, can this machine actually help us? And so then once those reagents were received a couple months ago, then we actually commissioned that instrument in terms of comparing what the results on that were like when we compared it to our ABA 7500s and the Quant Studio. And once we were comfortable in our mind that the process worked just as well, then we actually started to use the Roche Z480 when we had larger volumes of samples. Next slide, please. So we've had several other things going on in terms of our implementation. So along with the reagents that are recommended or are used in the charity protocol, we also had a donation from the Chinese government for a different test kit. At one point in time, when we also needed some swabs, our government had a discussion with Cayman Islands, and they were using another kit and they had excess of those kits, and our government actually purchased some of those test kits from the Cayman Islands as well. So we actually have 3 different test kits that we have access to in the lab at this point in time. And so one of the things we did with them, as long as any new test kit come, we always run a verification with at least 20 to 25 samples using known positives and negatives that we have stored. So majority of the samples that we have tested in our pandemic so far, we still have aliquots of those in the freezer. And so anytime a new test kit or extraction kits come along, we verify the different mechanisms that are working just as well. And we've had to do it along all the way, because sometimes, especially when we think of extraction kits, we were using QIAGEN initially, then we could not get the QIAGEN kit. We use Invitrogen, then we can get any more of those. So we have about 4 or 5 different extraction kits that we have verified in the lab to date. And we use our old samples, our stored samples, to be able to verify that these kits are all working and performing equally before we actually put them into circulation. And what I must say, this could not happen without the commitment of staff and managing the rosters. So generally our staff work from 8:15 to 4:15. Those are our standard government hours. My staff are there until, for the last few months, they're there until 12 a.m. every single night. And so that has been very taxing. I mean, initially when we started, we were putting in 16 and 20 hours because we were there from 8 o'clock and we were not leaving until 3 and 4 o'clock the next morning because we were just waiting on samples and we were not leaving until we saw the results. And then as time went on, we realized this is not sustainable being at work this length of time every day. And we start changing the roster. Some people come in the evening, some people in the morning, have an overlap when the majority of the samples come during the day. Still taking into consideration that other lab functions still need to take place. The other lab tests still need to be done, and we still needed to find a way to incorporate the routine functions of the lab and respond to COVID at the same time. So that is something that we have tweaked probably every month. We come up with something different, change something, switch around people so that to avoid burnout of staff, again, because it's only so few and the requests keep increasing. We've been able to have some volunteers. So we have some med tech students who were rotating in the lab when we had the shutdown. And they said that, no, we want to be able to help however we can. And even if it just meant coming in and accessioning our samples, assist with the separation of samples and labeling of tubes. We have a group of about 5 volunteers who are not only students, we've had persons from UE, we had a student who came back from overseas, and they all still come to date to volunteer on different days to assist us with any of the functions that we need help with. We've trained them up, so we're also training them to be able to do the extractions and the PCRs, of course, under supervision, but our intention is to get them fully on board and to actually employ them at some point. And so we started with the minor things, and then we're increasing their knowledge and capacity as we go along. So management of that has been well. Even those persons that come from the other labs, we've been having them do specific tasks so that we could kind of control the environment and the things that people do. Next slide, please.
Sonji, you have 2 minutes.
Okay, I'll be there. Okay, so in terms of our platforms, like I said, we have the ABI 7500, the Quant Studio, and we have the Roche Z480 platforms available. Right now, we're using the Roche primers. We have the kits from a kit from China and the kit from Sure Biotech that we can use, that we have at our disposal. Next slide. Some of our challenges has been procurement of reagents and supplies. It's really hard in terms of even getting shipments into Barbados. At times it's getting better now, but we've been having challenges with this. Shipping and transport within country, samples coming into us in a timely fashion has caused some challenges. Compliance with sampling, like I said before, sometimes the sites don't pack appropriately or the forms are not adequately completed. Again, managing staff burnout has been a challenge, and we've been trying to tweak this all the time. Again, manual extraction when we have large volumes is really time consuming. And when we move to extraction kits that use 2-mercaptoethanol, staff complain that gives them headaches. So then tweaking that and finding a way to work with that has been a little bit challenging sometimes. And of course, data management, accessioning, result reporting, etc., can be challenging. Next slide, please. So our lessons that we have learned along the way is that you really need to project your needs. At first, when we started, we were like, we probably only need 800 samples. And now I have procured probably more than 100,000 tests to make sure that we have what we need as we continue to ramp up. This procurement has to be timely because of the of being able to acquire the things on the market. Everybody is trying to get them. You need to be adaptable and flexible to change things as they're needed. We need to be able to mobilize staff as needed and share experiences with each other to make sure that we all benefit and learn from each other. And of course, the national effort, the highest level of support through this entire process is what has guided us and helped us to be able to reach these numbers. Next slide, please. So in terms of expansion, we looked at several platforms, the Gene Expert Express, we tried that and the Roche, but they're not available on the market. And even if you get the machines, access to reagents are a challenge. So we have stuck to our Z480s, which we have access to. We're going to invest in more automated extraction machines. We're thinking about additional testing site, a mobile site that we can actually post at the airport to reduce the lag time of samples arriving at the lab. We're working on additional staff. And again, forecasting and procurement of the reagents and supplies based on our known tourists, incoming tourists are what is important for us. So I would like to acknowledge and thank PAHO for the continued support. I'm sending Dr. Gresh several things as people ask me questions all the time. Help us to review our results and diagnostics and issues when we do have them. We've been able to enroll in a proficiency testing program through WHO, PAHO, the ECAP program, which is with the influenza. Again, the support by our government has been paramount. Support by the private sector in purchasing some of the items for us, and even some private enterprises has been great. And of course, we must mention the support of other regional agencies. CARVA has assisted us when we needed them as well. And without the RSS to ferry us and not only samples, but reagents and supplies to us when we needed them from the other islands has continued to assist us in everything that we do. So I'd like to acknowledge and thank everyone for their continued support. Thank you very much.
Yeah, thank you, Sonji, for sharing the experience from Barbados. So the way I'm going to be proceeding, I'm going to call Antigen Barbuda to proceed. Then we have Dominica. After that, we pause for questions. So bear with us. You can jot down some questions for the presenters, and then we give you a chance to either pick the mic and ask the question or send your question through the Q&A function. So I'm going to invite Dr. Lester Simon to proceed with his presentation. Dr. Lester Simon is a graduate from the University of West Indies at the University of London and the Royal College of Medicine. He holds a diploma in clinical pathology since 2009. He has been working as the director of laboratory at Mount St. John Medical Center, where he is responsible for the management of COVID-19 testing. In his private life, he is a co-owner of Healthy Choice FM, a family radio station dedicated to health issues. His hobbies include playing and teaching music. So, Dr. Simon, you have the floor. Please go ahead.
Good morning. I don't have any slides to present. I figure if I present slides, they may in fact be used in evidence against me. But I stand by every word I'm going to mention in this, in this presentation. I think reality came to us as far as COVID-19 goes around March 16th. Just returned from vacation when I heard the government, in fact, was very serious about doing PCR testing for COVID-19. And I chuckled then because my mind went back to how long ago I'd actually done any PCR work, which was 1987, 88. The other consultant pathologist, Dr. Goodwin, had just about, I think, 2 years post since becoming a consultant, and none of the laboratory staff had any experience whatsoever in molecular biology as far as PCR goes. I'll get back to the staff shortly, but as far as the actual building of physical structure was concerned, as I said, reality stepped in because later on that very afternoon, there was I think it was probably the next day, there was a visit from PAHO personnel because there had been some talk before that. And they came and visited Mount St. John and the old hospital and made the determination that the only place of the two we could do any PCR work was at the new hospital in the then microbiology department. So we had to make some renovation, and the details of which I wouldn't go into, except to say that when you're renovating something and your space is limited, it's a particular challenge. So we had that challenge of physical structure in terms of turning old microbe into PCR and turning part of histology into new microbiology. As far as the staff go, Antigua unfortunately didn't have the bevy of support I think enjoyed by a number of other islands, certainly not as mentioned in Barbados. Yes, we have an agriculture department here, and in fact, they had a PCR machine being sitting there for quite some time. But they want to go in some renovation, had to change from where they were to somewhere else, and we're in the throes of sorting that out. So as far as any personal concern, we had to rely on just the staff that we had in the laboratory. As I said, no PCR experience. There was some talk about getting some assistance from a university, a medical school here, but I made the decision then that if we were to do that and train them through PAHO, then what happens if they leave, not if, when they leave, because that's a sort of fickle situation, they go back on vacation, whatever. So I made a determination that the staff members who have been with us, in my case, in some cases, just before I came back in 1983 and certainly just after, these are the people who have been basically carrying laboratory medicine in Antigua, and these are the people who are to be trained. So there were 5 of them. There's 7 local techs in all, but 5 of them were slated for training, including the chief, including the manager. And of course, by the time the training got on board, this had to be done virtually because of the travel restrictions. And thanks again to, as we mentioned by everyone else, to PAHO and Dr. Gresh in particular for literally holding our hands virtually and taking us through this training literally from scratch to where we are today, to the extent where I think I was pleased when I heard some of the staff mention that you have to have respect for PCR, which means that we have come to realize this is not just any other test. And of course, we know that the bane of PCR work is contamination. And then, of course, we had issues like I think other countries have, where you had the public clamoring, when are you going to test, when are you going to start? And we had the politicians, of course, they're down on our necks because they were thinking it's time to open the borders. But it was a bit odd and in fact difficult at times, because at one stage we had situations we were told that they were not giving us the reports from CARFA because the laboratory was giving out data, as if there was this competition as to who's going to speak to the public first regarding the information from CARFA. We found that very, very annoying. I said, well, we as a laboratory, we're supposed to be the repository of data. How is it we're not getting the information from CARFA? It's not like we're giving it out. It's like bad old HIV days when people were giving out the result themselves and they're blaming the lab. So after some talking to the appropriate personnel, common sense prevailed, and we started getting the results in good time from CARFA. And then the borders opened when June 4th, I think. That was the prelude to that had to do with us getting the magic Sophia 2 test kits with the machine. Of course, not of course, but that didn't materialize. All sort of renovations were done at the airport, knocking down walls, getting negative pressure machines, and then Sophia 2 just didn't come for all sort of reasons which we can go into some other time. So it was only until around June 26th, the latter part of June, that we actually started doing testing in real time, of course, after the training, as I said, virtually with PAHO. And then we ran into, as we are right now, the situation where the demands are coming from surgery for elective cases. Of course, the demand has always been there from the community cases due to contact tracing. And of course, the demand is coming from those who are traveling. And there's this demand out there to test from the public. I keep on saying in camera when we have meetings, I mean, are we just going to go with what the public is saying or going with the science? Because when you talk about test, in my mind, and I think this is the same point, that the testing has to be guided by what I think is the heart and soul of COVID-19 testing, which is contact tracing. So some people will look at Cayman Islands and say, yes, but look at the history of Cayman Islands in terms of how the index case started. And then look at other islands that may be doing more tests than us, than we're doing. But could it be that they're doing tests because there's something coming up like a general election or something? So let's talk about testing, as I say in private when we have these meetings. But let's be clear what we're actually doing, whether we're just acceding to the demand that out there or we're acceding to the good science that contact tracing in fact is supposed to provide. So those are some of the challenges we have. We also have challenges with, and I have to say this, Antigua Antigua is a country where you do what you feel like and nobody tells you anything until it probably gets way out of control. And this is probably why I didn't put this in a slide, because that's the reality of the situation where you have private labs and private doctors who are doing what they feel like as far as COVID testing, antibody testing, and antigen testing. We have spoken about this publicly and privately, and they continue to do this to the extent where an antibody test is deemed to be positive, and then there's all sort of control that leads to in terms of shutting on this, shutting on that, and then found out to be negative subsequently. We have antigen tests being done, one that, in my opinion, is a tier below the Sophia 2, the SD test. And the person doing that test writes to CARFO and says, look, my test is better than PCR. And if I'm writing to you to get some authorization to do this test in Antigua. And some of this is being done, it appeared to me, not necessarily in concert with, but with the knowledge of people who are in government and who knows this person probably have some connection with this person. So we are fighting a battle as far as private testing is concerned. And I think, quite frankly, COVID testing should be a public issue. And if the private sector wants to help, there have to be certain outline conditions under which not the free-for-all that obtains in Antigua. I think the crucial point, however, the crucial point that I have learned, and I think all of us need to learn in Antigua about PCR, is rather ironic, because we talk about contamination being the bane of PCR testing. But guess what? I think in a rather ironic way, we could probably say that PCR is the bane of laboratory medicine, in the sense that PCR has opened up this whole question, a lot of questions that have been buried and overlooked as far as laboratory medicine is concerned. Nobody knew who technologists are. They're not paid what they're worth. In fact, the situation we have right here is we're being overwhelmed. Our staff, I mean, they're doing PCR work, they're doing regular work. We, in fact, tried to increase our capacity by getting additional staff. 2 people applied. 2 people were interviewed. And one of them said, you must be joking. I mean, in this time where, it's hard to get a job and keep a job, literally walk away from the miserly amount that is being offered for PCR work. So that, to me, is a crucial point that PCR testing has opened up, because are we going to now have dedicated PCR workers who just come and do PCR work and nothing else? Or, and this is what I think, you should have workers who are doing laboratory technologists who are doing PCR work, hematology, and other things. That is what, in fact, we can afford, because if we don't do that and the PCR technologists get bumped up in terms of salary, that's going to create a sort of disharmony in the laboratory, which is not something I think I would certainly not stand for that. So the crucial point I'd like to make as far as building our capacity is concerned, we talk about reagents, we talk about supplies, we talking about even getting in an automated extractor, a machine, which I got it from CARF, can run into some issues in terms of contamination later on. That will help to some extent once we, taking care of it in certain ways by following those guidelines to prevent, again, this bane of PCR, whether it's manual extraction or automated. But again, like I said, to me, my learning point in all of this is that PCR has opened up some wounds that have been there, certainly in laboratory medicine in Antigua, where we're the lowest, if not the lowest, then very close to the lowest laboratory technologists, paid workers in the Caribbean, to the extent when you try to get people in Antigua, you don't. And so therefore we end up getting a number of Cubans here. In fact, you have what, roughly 8 Cuban technologists to 7 Antiguan technologists here. So in terms of how we're going to build capacity, a fresh look has got to be taken on laboratory medicine in general. And this to me is what PCR has opened up. Thank you.
Yeah, thank you, Dr. Simon, for your intervention. We come back to you for questions. We are proceeding with Dominica. Dr. Ahmed, are you ready to give us the experience and lessons learned from Dominica? You have the floor, Dr. Ahmed.
Good afternoon, everyone. Thank you.
So, Dr. Ahmed, yeah, just maybe a few words about who you are before you proceed. Dr. Ahmed is an epidemiologist by training. He works for the Ministry of Health of Dominica, and he has very good relationship with the National Reference Laboratory for his country. Since January 2020, he has been involved in the development of COVID-19 surveillance and testing guidelines, and played an important role in the design and implementation of a COVID-19 seroprevalence survey using antibody test. In his current position, he advises the Ministry of Health of Dominica on border reopening protocols, including testing requirements, and participates in the evaluation of travelers prior to traveling to Dominica. So, Dr. Ahmed, you have the floor. Please proceed.
Good afternoon. You guys can hear me?
We can hear very well.
And can you see my presentation?
Yes.
Okay, thank you. Okay, I am not sure exactly that I should be here. I mean, looking at the concept note and presentation so far, it's all about lab. So, nonetheless, I'm going to start with some epidemiology of COVID-19 in Dominica, and then go into surveillance strategy and the testing procedure that came along during all through our surveillance of COVID, and then the capacity that we have and some of the challenges. So in terms of our epidemiology, as you can see, our first case was identified in 21st of March. That was first time the index case 1 was diagnosed. And then we had March 2nd, actually, 22nd was the second index case were identified. And then March 23rd, we received, I mean, those who were, we did the contact tracing for index 1, we did the PCR testing, and then we identified 9 of them. 9 of the contacts came from those index case 1. And subsequent to that, we had other cases. Those were mostly contacts, except 2 other cases where they were from different locality. And the last 2 cases came from our cruise ship crew members who were in cruise ship and they returned home. And those were positive even before they actually docked on our shore. So in terms of our number of cases, the total number of cases, that is lab PCR confirmed cases, 18. 12 of them are male, 6 were female. There were no death. The age ranges from 18 years to 84 years. Median age is 51 years. In terms of geo-distribution, these are the locality that we had the initial cases, the initial index cases. One in La Plaine, that is in East Coast, south and East Coast, east side of the island. And that's where we had the bulk of cases, almost 10 cases coming from that area. Then we had Northeast again, another area location where we had about 5-6 cases came from there, and 1 case from Roseau area as well. But that cases did not have much contacts. Now, in terms of going into details as to our cases, the index case that we had that was identified in March 21st, It came from the area called La Roche. We had total of actually 43 contacts out of this one individual. 14 of them were direct contacts, and of them 9 were positive. And then of those 9, then we did further contact of the contacts, and then we identified 29 of them, and they were all tested using PCR method, and they were all negative. In terms of index case 2, who actually, matter of fact, he isolated since he landed on our shore, right from the beginning. So he kept physical distance at the airport, at the immigration booth, and then subsequently from his family. He stayed upstairs and his family stayed downstairs until he was tested and he recovered from it. So he had very minimum contacts, roughly about 4 of them. We tested them all, they were all negative. Index case 3 came from another location called Concord. She had total of 59 contacts, 20 of them direct contacts, of them 2 were positives. And of those 2 positives, we had 39 contact of the contacts. And then there were 1 positive from the secondary contacts. So, and all of them were tested using PCR method. Now we had index case 4. Let me just explain index case 1, 2, and 3 in terms of contracting the disease. Index case 1 came from UK. Index case 2 also came from UK. Index case 3 did not go outside. However, she's running a guest house. So she actually had some guests coming from Sweden, came from Sweden. So they stayed there, about 6 of them. And one of them, she mentioned that one of them had flu-like illness. However, we did not get the guest before the guests, all guests left before she developed the symptoms. So as a result, we could not really verify that her contacts were indeed from those guests came from Sweden. But the index case number 4 did not have any connection with index 1, 2, and 3. However, person is a policeman, and he developed a mild symptom, loss of taste and smell. And subsequently, he was tested and he turned out to be positive. He was deployed in one of those high-risk area, La Roche area, for some time. But we have traced about 47 contacts of him, and we tested them, and they were all negative. So this is a unique case. Hypothesis is that he must have contracted out of the index case either 1 or index case number 3, because he did have some communication with index case number 3, family of index case number 3, but nonetheless there was no definitive finding as to how he contracted the disease. In terms of our case management, only 4 were symptomatic. 4 were symptomatic, not so severe. Only 1 had shortness of breath. 3 of them had fever. 1 had shortness of breath. Not shortness of breath by itself, fever and shortness of breath. The other one had fever and cough and cold or runny nose. And 1 other individual had only diarrhea, no fever, nothing else. However, she was tested and she was positive. In terms of asymptomatic or mild symptom cases, we had about 13 out of 14 of them did not have any symptoms. Those were identified through our contact tracing. Only 1 who had mild symptom or had loss of smell and taste. That's the only person who had mild symptoms. The comorbid conditions, about 6 of them had comorbid conditions, and their age ranges from 80 and up, 78 and up actually. So they all had hypertension and diabetes. All 18 were managed at the COVID treatment facility. We actually admitted them, all of them, at the treatment center, and we kept them for 14 days. After 14 days expired, we did the PCR test twice. We tested PCR twice in 24 hours apart. And once that second PCR negative, then they went back to the community. That was the criteria of sending or discharging the clients confirmed COVID cases from our facility. We had few, about 4 of them needed to stay longer than 14 days. About 3 of them stayed over 28 days, and only 1 stayed almost 42 days before we found the client's test results negative. 2 test results. In terms of a treatment course, all of them were provided with the basic preventative therapy. Additionally, some were given some oxygen therapy. Also, supportive therapy was given as well in terms of their comorbid conditions. Those who received the preventative therapy or basic preventative therapy include zinc, vitamin C or multivitamin. Some received azithromycin and levofloxacin, and some is oseltamivir were given as well. Now, in terms of the surveillance strategy, so in terms of the health surveillance strategy at the health facilities, that started actually even before, sometime in January, and that same surveillance strategy is still ongoing. In terms of monitoring our ILI and ARI cases, we collect samples randomly, at least 1 or 2 per health district per week for COVID-related testing. We are also monitoring SARI cases. So I collect samples from all SARI admission cases. At the ports of entry, prior to lockdown, initially we started sending all arrivals, all visitors, nationals, residents, and non-nationals, for home quarantine for 14 days. And that lasted up to mid-March, when we actually locked down or shut down the entire country and shut down our border. So during that period, we used to send the visitors home for home quarantine. And then after mid-March, those who are coming again, we were placed them at the government quarantine facility. The time period was 14 days. And once they are tested negative using the PCR method, then they will discharge them to home. Those who repatriated, they were placed at the government facility as well for 14 days. And test was, once tested, PCR test became negative, and then they were sent home. So prior to going to home, all those came through our ports of entries. They were directly sent to our government quarantine facility until 14 days. In terms of going forward with the reopening of the border, our surveillance strategy include pre-arrival screening, and that includes two requirements. That includes a screening through online questionnaire. So every visitors must fill up that online questionnaire, and also have a negative PCR result that was taken or done within 72 hours from the travel date. So that's the requirement for our pre-arrival screening. And on arrival screening at the ports of entries, we do temperature screening. We do a rapid test for all passengers coming in. I mean, of course, those who have the PCR negative. There are some exception to PCR negative cases. These are dealt with the exceptional protocol, with the waiver, and those clients or those visitors are required to do PCR, and they are sent to the quarantine facility, government quarantine facility, until the PCR result is out. And from there, once they are negative, they are sent home for 14 days home quarantine. And those who have negative PCR result during pre-arrival time, they are asked to do rapid test. Once rapid test is IgM negative or non-reactive, then they are allowed to go through their normal immigration, clearing the immigration office, and go to their home with clear instruction on mandatory 14-day home quarantine. In terms of the rapid test results, we indicated that if IgM positive, then those clients will be sent to our secondary screening area, where we will be doing the swab and sent for PCR testing. And they will be placed at the government quarantine facility. They will not be sent to home until the PCR result is out. And once PCR result is out, they will be given the instruction to stay home for 14 days, mandatory. At the community level, this is still actually a plan being implemented as of this week to conduct COVID or ILI or ARLI clinic in all 42 type 1 health centers at least once a week. We also have implemented to visit the catchment area of each health district once a week to do the temperature screening, to screen individual for clinical signs and symptoms, and collect random samples. We have not decided as to how many. It depends on our capacity. That's yet to be finalized. In terms of follow-up or following up all returnees via phone and visit is ongoing. So those who are coming now since June 15, they are being followed up by over the phone, and our community health nurses and the community health aides are visiting those guests and collecting information. At the community level, we also did during this COVID period, we did community-based screening. That is sometime in May. We did this, and the objective was to see if any active cases of COVID in the community level. So we conducted that screening process, and that included temperature check, administering questionnaire with the data, demographic data, exposure information, clinical presentation, and chronic medical condition. And we also did the rapid antibody test for them as well. We randomly selected 600 households in proportion to the health district population around the island. There were about 1,100 who were tested using rapid test kit. The response rate were about 98%. We were able to capture most of them. Only 2 were reactive using this rapid test kit, and they were subsequently they were negative on PCR method. Now, in terms of our PCR testing capacity, actually strategy for COVID include that we plan to test all suspected COVID-19 cases. Then a limited amount of randomly selected ILI and IRI cases also will be tested using the PCR method. All SARI cases will be tested using the PCR method. All our frontline workers, we already did our healthcare sorry, not health officials, but healthcare providers. We did those who were in or giving the service at our COVID treatment center, as well as COVID isolation unit. We plan to do for our immigration officers as well as ambulance driver. We also plan to test our nursing home care people. Right now, we are also doing PCR testing for those who are going out of Dominica or traveling abroad. And we also doing some visitors coming back to Dominica, those who do not have a negative PCR result prior to arrival. A little bit of PCR testing capacity, just to say that we were fortunate to be among the first in the OECS countries to have the in-country PCR testing capacity, and thanks to PAHO for the equipment and Dr. Gresh for training. It was very timely, and we had the opportunity to do the PCR testing for our returnees. That was as early as in February. So we did testing for those returnees as well, especially those who came through ferry, Guadeloupe and Martinique and Saint Lucia. PAHO has been supporting us all along our COVID period with our testing supplies, with our swab sticks, with PCR kits, consumables, extraction kits, etc. So far, we have tested 1,117 individuals as of yesterday using the PCR methods. PCR testing remained the only diagnostic testing method in Dominica. And we have the only public lab that performs this PCR method at this time. We also expanding our PCR capacity. I believe IAEA provided a PCR equipment and some reagents, but there are some works to be done at the lab, and then we will be able to use more samples than what we're using currently. We have received some PCR kits from China as well, thanks to Chinese government. However, I believe our lab is in discussion with Dr. Gresh with respect to the specification of the equipment and the kits provided by the Chinese, how it can work out. In terms of rapid testing, we have used rapid testing method only for screening and not for diagnostic purpose. If there were in the past that we did some rapid testing, if there were any reactive cases, our plan was to do the PCR testing to confirm, as it happened in our community screening, community-based screening, where we found two IgM or two reactive to a rapid test kit, and then subsequently we did the PCR test to confirm, and those were negative. We did not use rapid test or do not use a rapid test to confirm a suspected COVID case. A suspected COVID case will clinical presentation or contacts of a confirmed COVID case, we only do PCR testing. Rapid test kits are being used, as I mentioned earlier, community-based screening, as well as at the airport as second-line screening. Those who are already tested negative using the PCR method, and when they come to our shore, we do further using the rapid test without any cost, of course. Just to say that we also, so far, we have completed about 1,200 rapid tests, and most of them, except two scenario, most of them, all of them were negative. In terms of our challenges in testing, time to time, short supply is the biggest challenge. We short supply of swab sticks, sometimes PCR kits, and sometimes timing of samples are received by the lab or sent to the lab. It's not consistent with the one timing. Sometimes it's in the morning, sometimes it's in the afternoon, and turnaround time is 24 hours. So that caused a bit of confusion as to the receiving the result and producing the result. So these are
Your
the
time
challenges.
is up. Your time is up. We can come back to you during the question and answers.
Sure.
Yeah, we are going to be. Yes, okay, thank you very much. All right, so let's now proceed with Martinique. We are going to hear Dr. Jose dos Santos, and then we are going to wrap up with the question and answers by the participants. Dr. Jose dos Santos is a graduate of the Pierre and Marie Curie University. He holds a PhD degree in molecular biology. Since 1997, he has been working at the University Hospital Center of Martinique, where he specializes in HIV antimicrobial drug resistance, his main area of research. He also holds a teaching position at the Faculty of Medicine of Antilles, where he teaches molecular biology. Dr. Dos Santos, you have the floor. Please proceed with your presentation.
Thank you, Jean-Marie. Good morning to all. I've got no slide on my. And today, I'm only the representative of my lab because the people who made all the work is currently out of the lab. She's in vacation, the head of the virology lab, and she will have much better than me, will have speak of experience. My presentation will have, my speech will have two times. I will first describe what happened in Martinique at the level of testing. We first start, there were two periods. The first period is between mid-February and mid-May. And during this time, it corresponds to the more important part of the time of the epidemic. About 3,062 people were tested. Among them, 180 were positive. After that, since then, the possibility of testing in Martinique grew up, and the testing began out of my lab, but it began also in two private labs. And currently, since May, about 12,000 tests were performed in the different settings. Finally, today, 269 people were tested positive in Martinique. Among them, 45 went to the emergency unit, and 15 died of the coronavirus infection. So two times before, the first period of the testing, where mainly all the tests were done at my lab, and we began following the French national recommendation, doing PCR testing, homemade PCR testing with protocol from Institut Pasteur. So we started and we performed at the main time of the epidemic that correspond to March, where we saw the most of the positive people. At this time, half of the people that were tested were positive by the end of March and the beginning of April, and this corresponds to the worst period of the epidemic in the island. And then, with the help of the French ministry and its representative here in Martinique, we access to kits, to Antigen kits, Korean kits, that were that permitted to speed up the processing of the testing. So since then, at the lab, we perform testing with the Antigen coronavirus kit, and the same kit is also used by the private lab. The main difference is that the main problem was the problem of extraction. And we face it, and because with the pre-treatment that is supposed to be done, this introduced a lag time in the processing of the samples, and that was the point. because you can imagine in my lab, it's not only we have to face the epidemic, the coronavirus epidemic, but we have to also to continue to provide testing for all the other virus infection in the hospital, for the patient of the hospital. So it was an amount of work, a great amount of work with only 7 technologists working in the lab with a kind of material that we had the experience of previous epidemic as dengue epidemic or Zika epidemic. So we were equipped with automated extraction machine as the EasyMag we used, but the problem is that there was a big manual component at the start of the processing, and this was very time consuming for the technologists. So we introduced then those kits from Korea, and we're now expecting new machines to do the PCR and the extraction in semi-automated way. Such machine are Nimbus machine that will permit us to do 70 extraction at one time, and doing the process and distribution of the mix, master mix, PCR mix into the plates in order to speed up the process. And we expect to have this machine by September, because with the shutdown in the island, there was very few access to exchange with France, where all the reagents come during the period. So I think that this is the big experience that we had, that it was to be able to provide the number of tests that were necessary at the time of the epidemic. And now we're mostly testing people coming to the emergency ward, and also people coming without positive test at the airport. That should not be, because now you have, when you come to Martinique, you have to get a pre-flight negative test. So therefore, we are now in a way to prevent a possible second wave, just to have a sustainable capacity of performing more tests and if needed. So this is the way we're now moving to. We also introduced the use of Gene Expert. Now we're using Gene Expert because it permits us to give a quick and fast response for people who need such an emergency case. For example, for people who want to have surgery in an emergency, and they as a pre-test is recommended, we use the Gene Expert to give the results in less than 1 hour. So this speed up the process, but this won't this does not permit to make the number of tests done bigger. So that is currently the orientation of what we want to do. We also introduced since 1 month antibody testing using architect's serology, but this is mostly to check if people have been in contact with the virus previously, mostly for people working in the hospital, and to people that should have been exposed to the virus. This is currently the recommendation, but we expect to have more testing, because now testing is free in France and we have no, don't need to have a medical prescription to have access to the test. So at the hospital, we expect to have more testing, as also in the private labs. This is the point at the moment. I think that's it's all for me.
Okay, George, yeah, thank you very much for your presentation. All right, so we are now going to be moving to question and answers. If you can allow me as the moderator to ask a few questions. I will start with Sonji. Sonji, thank you very much for your presentation. I know Barbados had the equipment at the very beginning, and your training started very, very early. And maybe this is explained why you have been able to do so many tests so far. But moving forward, my question to you would be, in terms of strategies, do you have a target number of people that you really want to reach as a country? How are you approaching this? For Leicester, the issue of laboratory reagents and supplies, it has been mentioned by all the presenters that they can be a limiting factor in increasing the capacity for testing. Do you have a mechanism for prioritizing who you are going to be testing in Antigua and Barbuda? Are you testing everyone, or do you have really a group of people that you have identified that you want to prioritize? Dr. Ahmed, your topic was about the role of serology in testing for COVID-19. Unfortunately, we did not have a lot of time at the end, but my question to you is, according to what we know, and it was also confirmed by Dr. Lionel's presentation, there is no antibody test available on the market which has been validated for diagnostic purposes. So the rapid test that you have been using in Dominica for various purposes, whether it's at the airport or community level screening, did you do any in-country validation? And if you did, what was the results? For George, yeah, I appreciate that capacity was available at the beginning and you continue to build more capacity. Can you make a few comments about quality assurance for COVID-19 testing in your laboratory? So I will invite each presenter to make a few, to provide an answer to that question, and then we open up for further questions from the participants. Sonji, you have the floor.
So hi, thanks for the question. So really, in terms of our test strategy, that's what you asked in terms of what we are doing. What we have noticed for all the majority of the persons that were tested in Barbados is that they were asymptomatic and had very mild symptoms. So at this point in time, in terms of our offering of testing, it's really for anyone. First of all, anyone who's symptomatic, and then persons who also just would like to have a test can also approach the healthcare system to require, to ask to have the test done. So it's not only persons who are symptomatic that can approach the healthcare system for a test. Basically, anyone can approach the healthcare system to request a test. However, in cases where we do have positive persons, of course, our contact tracing then would reach out to everyone that person may have had some level of contact with and do testing on them as well. Also to note, in terms of our numbers, I must say that all the numbers that I've presented are not only Barbadians, but also we have been doing some testing in between for persons on the cruise ships who are returning to their countries of origin and are passing through Barbados as well. But really, anyone can approach the healthcare system for a test if they require one or request one.
Antigua, obviously, anyone who is symptomatic and meet the criteria, they're obviously priority for testing. We also have pre-op patients and travelers, those who are going to countries, which is in essence just about everywhere, where they need to have a PCR done. But the bulk of the testing that we do actually coming from the community where folks have discovered because of contact tracing. And this is where I think the emphasis ought to be. As I said earlier, I think contact tracing is the heart of this matter, because quite frankly, you have a number of people, I suppose you could put in a way to say the world and his wife wants to have a test done. I mean, I was in a meeting where it was said, look, maybe we should go and test some folks in old people's home. I said, well, look, we haven't had, in fact, another person said this as well, we haven't had any cases from that particular home or those homes. The workers are there. So I said, look, why don't you assume that the workers are all positive and they continue to do what they're supposed to do? They're asymptomatic. They continue to do what they're doing in terms of masks, in terms of social distancing, including, of course, the decrease in that distance when they have to feed or look after the person. And they carry out the hygiene. In essence, in 10 days' time, what happens? You know, they remain asymptomatic. They are, in fact, in a sort of virtual, if you wish, don't want to use the word isolation, maybe she use the word separation. So why do you want to test them for what? You know, these are asymptomatic. You haven't had any cases there. As I said, they're asymptomatic. And in regards to people who want to just have a test because they want to have a test, I'm totally against that, because you know what it reminds me of? It reminds me of the bad days of HIV, when people, in fact, what I refer to them as serial testers. They carried all sorts of risky behavior. They come to have a test done, and they depended on the test to determine whether that risky behavior last night or last week was good or bad enough, and therefore, you know, and then they upscale their risk from risk 1 to risk 2. So this idea of just coming to have a test because you are asymptomatic and you just want to have a test, in my opinion, I think the resources, certainly for us, should be for the cases the conditions I mentioned earlier. But again, whatever capacity we're gonna need to even include the cases that I mentioned, we need to have more people in. And again, I've mentioned that already. I'll stop at that point. At this point.
Ahmed, any validation results for the test that you're using for rapid testing?
Sorry again. We didn't have any what is that called, official validation for any rapid test kits on the island. The rapid test kits that we had, we used for community-based screening, we tested few of them, about nine positive cases. We tested them, and those were, I mean, almost 70%, 60 to 70% were exactly the same. I mean, showing a reaction or reactive to those individuals. But we did not have any testing, any negative cases, which we did not. I'm not sure the lab did not have the capacity or did not have the time to go ahead with it. So we just use the rapid test kit as it is. The kits that we are using now at the airport are not validated. We went ahead with the manufactured accuracy level in terms of their sensitivity and specificity. They provided us with that, so based on that, we use that rapid test kit. As I mentioned earlier, these are not diagnostic purpose. It's only a second line or screening purpose we are using.
Thank you very much. George, any comments about the quality assurance mechanism in your laboratory?
Yeah, the lab is involved in the quality assurance management process as COFRAC, what's the name in English? 15189. But for COVID, I think that we had some external quality testing coming from the national reference center in France, that maybe the Institut Pasteur that sent us some samples to amplify and to serve as external quality assurance testing. But also the kits we use includes their own internal control and so on. So it is securing the testing. The main problem that is with all these tests with is from the experience was a negative test is it really a negative test? That means that it's so dependent of the quality of the swab, because if you have no cells on the swab, you will give or poor cells on the swab, you'll give a negative results. So that's what the main focus that we worked on. It was on the quality of the swab to be sure that there was some cells, and then to provide some to be sure that negative were real negative and not poor quality swabs samples.
Yeah, thank you very much. All right, so now we're going to be taking questions from the participants. I see Trevor Noel, you have your hand up. I'm going to give you the floor. Trevor, please go ahead.
So he also typed a question in the chat. I can read that question.
Yes, please. Yes, you can go ahead with the questions.
Okay. Can you comment on the pooling of samples in low prevalence countries?
That will be for Lionel? Or is it related to the country experiences?
It didn't say. It just reads, thank you for the interesting talk. Can you comment on the pooling of samples in low prevalence countries?
Maybe, yeah, sorry, this is Lionel. Maybe it'd be interesting to hear from the countries if they used it or consider it. And then I can say what our official position on that is, or recommendation on that is.
We have neither used it nor considered it in Antigua.
Yeah, we have not used it in Barbados either. We're not considering it at this point either.
And this is not in the recommendation, not.
Lionel, do you have any power position on this?
Yeah, I think it's a similar position. I think our position is that it's still a bit early to know. There are a few studies, but I think we really need more data to be generated on this. One thing that is important, as with any testing to consider, is who and why you're testing before deciding if you pool samples or not. What I certainly don't envision is us doing pooling or recommending pooling of people, for example, who are symptomatic and might be or high risk or so. But they might be, and I'm saying it's not the recommendation at this point. But once we get more data on how pooling performs, there might be a space for this testing to be considered, despite its likely loss in sensitivity. So depending on what's your testing strategy and why you're and who you're testing with at that pool samples, it might make sense to do it in some context. For now, the recommendation, as colleagues from the countries mentioned, is test individual samples. Over.
Thank you, Lionel. Brenda, can you read 2 questions from the audience, please?
Yes, sure. We also have 2 other participants with their hands up, but I'll read a question first. Eastern Caribbean, in the Eastern Caribbean, some countries are conducting repeat RT-PCR tests 7 days after being negative in the entry screening of visitors using RT-PCR tests. Any comment? And then, can you comment on fake PCR test kits sold in the market?
Anyone from the country representatives or Lionel?
I think the idea of the 7 days is based on the fact that if they're coming with a negative PCR, that negative PCR may just be, I'll use the term, a false negative, in the sense that a patient may be in a pre-symptomatic stage. and they would expect them to therefore be symptomatic, at least, not necessarily symptomatic, but to be able to show a positive test 7 days after, at least. I don't know why 7 is chosen as opposed to 5.
Maybe George, correct me if I'm wrong, but I think that that's the strategy, right, in Martinique, that you should come with a negative test and then get tested after 7 days. Is that still the recommendation there?
This is a recommendation, but to be tested 7 days after is not mandatory at the time. It's no more mandatory.
It's not.
This is recommended, but you're not. This is not an obligation.
Thank you.
Because there is so now I was looking at the last currently the positivity is 0.3% in Martinique. So this is a very low prevalence, even coming from outside.
But I mean, if you're negative and coming in, right, the person is asymptomatic, obviously, and coming in, and remain asymptomatic, and obviously the only danger you can be thinking of is that the person is now positive because the PCR was too early and run the risk of transmitting the virus to someone else. But whether you do that test or not, mask and the distancing and the hygiene still obtained. So why are we really doing that test? Are we just trying to satisfy what?
Lionel, do you have any comment about this?
Yeah, no, I agree in a way. I think for each, when especially, I mean, in an ideal world where you can test as many people as you want for as often as you want, then these questions might not be that relevant. But you're right. I think right now, especially if we want to expand testing capacity, we have to think for every test we're doing, why are we doing that, and what's the impact in terms of public health or individual decision. So you could, well, I mean, depending on the conditions of where you could say, okay, I'm not gonna do the testing on that person coming in, but I'm gonna impose mandatory quarantine for 14 days. And that would save, in terms, strictly speaking, in terms of the transmission of the virus, it would serve the same or even a better purpose, because you won't care about when the person got infected, is he pre-symptomatic or not. The person will be isolated for 14 days. Of course, that's looking only at the problem from a sanitary perspective, and there are other considerations to take in mind. And when those other considerations, like reopening the economy, allowing tourists in to come in, then that's when you have to start thinking what's your balance between what testing you can do. I think also important is always, and I think what Dr. Ahmed mentioned from Dominica seemed to be along those lines, is that it doesn't give, that the negative test should never give you a false sense of safety because of that pre-incubation period. So people should always be told, okay, you're negative now, but if you've been exposed in the past 3 days, you might still be infected, and you might then be a spreader of the virus later on. So I think those are the issues we have to consider. Over.
Well, it seems to me what is up here is that a test is something which is objective, which you can do. You can take a sample, you run it, you get a result. The other side of that, which is the social distancing and the mask and the hygiene, we have relatively little control over that. So I'm just worried that we are moving into a phase where we're going to be putting too much emphasis on testing rather than the other aspects of controlling this virus.
Well, Dr. Simon, you are very right. The response should be balanced. It's not just testing. Yeah, other aspects of response are equally important. So striking a good balance in resource allocation is going to be very critical as we move forward. Okay, so I'm going to take two questions from the screen, and then we go back to the chat. Seawater and Cresta. Water, can you take the mic?
Good day, everyone. Thanks for the presentation. Can you hear me?
Yeah, we can hear you.
Okay. I just wanted to add to what or correct what Dr. Ahmed presented and to state that we have done a measure of validation, limited maybe, but on the kits that are being used, the serological testing that is. So the one that is being used now, we use 16 of our positive PCR positive cases. Samples that were collected post PCR diagnosis, and we use that in our validation. We used, like in this, the one that is current, we use 84 of our donor samples from 2 years ago. That is from January to March 2019. And the assumption is that these would be negative, seeing that they represent the pre-COVID era. And we use the 16. So we have done some validation on that. There are other kits that we have also used, well, not used, but experimented with, and we've used that same battery of negative and positive to also do validation on them. We are also using this same test serum on a ELISA method that Ortho Clinical is manufacturing. And so far, so good. Even today, we are running a series of tests on them, and the results all match up. So I just want to say in a nutshell that, yes, we have and currently are doing validation on all the kits that we come into contact with. Some of them may not even be what we're using, but once we get the kit, we try to do some validation on it. But yeah, the idea is we're still going PCR, PCR, PCR.
Yeah, thank you very much for this supplement of information on the validation process in Dominica. Yeah, that's the best way to go until we have a test on the market which have been validated officially. So I see that Cresta, you have lowered your hand. We go back to the chat. Brenda, you have two more questions?
Yes. Dr. Simon, I heard you mention the antigen test. Is Antigua using it, and how effective is it? Do you recommend it for small items like us in Nevis? Was it validated and accepted?
The antigen test we're using at the hospital is a Sophia 2. They actually arrived sometime after they should have arrived for June 4th when we opened the borders. We have 5 such machines. You may be familiar with the kit. It has a small machine, has a very small footprint, almost 3/4 the size of a laptop. Well, in terms of length and width, but obviously much thicker than that in terms of its height. We use it at the hospital. We're going to be putting one at the airport, but at the hospital we use it if a person comes in and is going to have emergency surgery. There's no time to do a PCR. We run it on the Sophia 2. The Sophia 2, when we got it, we actually said to Carrefour, look, you sent out this guidance document regarding how to evaluate test kits. Could you do that for us? And they did that and put the Sophia 2 in a category C. Category A, of course, being PCR and gene expert. Which reminds me, if Martin is getting gene expert, we want to know where you get the cartridges from. Anyway, so that is how we will work the Sophia 2 at the hospital in such an emergency situation. In fact, today we have some folks coming in who need to travel. They've been doing some PCR overseas, and they're traveling very shortly after arrival, and we're going to be doing the Sophia 2 on them. What is confusing, folks, is that there's another antigen test being done privately, And that to me is a couple tiers or maybe one tier below the SOFIA 2, because as you may be aware, the guidance document CARFA put out had some 14 parameters. It's approved by FDA, by the European Union, etc., cost, whatever. When I just look at that test that's been done privately, I think it will fall below the SOFIA 2, which, as I said, got a category C, which means that for every negative you get, every 1 in 3 of those negatives have to have a PCR done. So to answer you in a more practical sense, if a patient has signs and symptoms suggestive of COVID, that's where the antigen test seems to have its strong point. Certainly with the SOFIA 2. In fact, a similar thing was done for that private testing procedure, an SD kit, which, as I said, falls below the SOFIA 2. And those were positive. And, you know, surprise, surprise, the whole island thought that validated that particular testing procedure. I had to say to someone, I mean, if the chicken tastes good, it doesn't necessarily mean that the pork tastes good, which was just a way of saying that if the positives are good, it doesn't mean the negatives are good. So we're in that bit of a confusion here. But to answer your question quite simply, if you get an antigen test, either of the two that we're using here, they're good for the positive ones with their symptoms. With the negatives, you're going to have to do PCR. In fact, some people would say, look, they haven't been tested by FIND, so you probably should do the PCR as in fact on both the positive and the negative, because that ties into how you're going to aggregate your data. You're going to put those data separate, or if you're going to put them with PCR, you certainly have to do the PCR after the positive ones. And as I said, after 1 in 3 of the negatives, if there is a SOFIA 2, or some people say all of them should be tested subsequently.
All right, so thank you very much. If we can take just one more question and then we'll be done for today. Can you read us one more question and then we will through?
That's it, no more questions. Over to you.
All right, so thank you very much.
Sorry, Jean-Marie, can I then make a small comment about the gene expert, what just Dr. Simon mentioned?
Yeah, please go ahead.
Okay, very quickly. So as I mentioned quickly during the presentation, the UN has established the COVID-19 supply chain system that has one of the consortia within that supply chain system is the Diagnostic Consortium that has negotiated with manufacturers of open platforms, but more importantly, closed platform assays kits, allocation for low and middle income countries. Those allocations, it's not a donation, is an allocation to the country, and the country can then, with either its own funds or a development bank funds or any other fund, access, procure those kits. The allocation, it's relatively small. It depends on basically on the size of the country and on the level of income. We've had a lot of fighting from the PAHO perspective to have small island developing states that are classified as high income. I think in the ECC regions, Antigua, Barbados, and St. Kitts included in that process. And as far as we know, that has been agreed upon now. So I encourage you to I think we've mentioned with Dr. Jean-Marie to, within your response plans for the next few months, consider that allocation, although it's small, but how this allocation could be best used to scale up your testing in, as George was saying, maybe for some specific applications like emergency surgeries or other times when you really need a rapid testing. Over.
All right, thank you very much, Lionel. Yes. All right, so thank you, everybody, for coming to this webinar today. We are reaching the end of the session. So in summary, well, the guidelines from PAHO are very clear in terms of some of the things that you have been asking for: the role of antigen detection, for example, the role of testing for discharging patients who are isolated. All those things have been clarified. From the countries, we understand capacity is being built. there are so many factors which have been contributing to the progress which has been made. Political commitment was mentioned, partnership within the country, but also with the regional and the international institutions. There are some other factors which have contributed as well, like cooperation between countries when it comes to a shortage of certain laboratory reagents and supplies and others. In terms of challenges, there are some challenges which are common to many countries. For example, the limitation of reagents and supplies on the market, which I just mentioned, but also availability of so many kits, whether it's testing kits, extraction kits, and others on the market, and you have to make very difficult choices. Staff management and burnout was mentioned as an area which needs to be looked into. Of course, the validation of rapid tests is an issue that countries have to continue to deal with until WHO has validated those rapid test kits. So I'm going now to hand over to Dr. Gebre for his concluding remarks. Over to you, Dr. Gebre. So Dr. Gebre, I think he might be in another meeting. Okay, so this brings us to the end of the meeting. We thank you very much for attending. I hope that we have another opportunity to exchange on these very important topics regarding laboratory. If you have any questions, feel free to send an email to any of the presenters and they will be able to get back to you. So I wish you a good afternoon and enjoy the rest of the day. Over.